Hello, my name is Pratik Sharma and I'm a Senior Clinical Lecturer, Consultant Orthodontist based at the School of Medicine and Dentistry, Queen Mary's University in London. It gives me great pleasure to prepare this brief video to introduce a clinical study we undertook, which is due to be published in print in the September edition of the AJODO, and I would refer you to that edition for full details of our findings. There is no doubt that orthognathic intervention can result in positive outcomes for our patients in relation to improved dental and facial aesthetics, function, health, and psychosocial well-being. However, such interventions are not without risk, and as clinicians, we should be able to inform patients regarding the risks associated with orthognathic surgical procedures, as well as their potential impact. Neurosensory deficit, or NSD, is a commonly reported complication following LeFort 1 surgery, with a highly variable incidence reported in the literature. The long-term outcomes have not been comprehensively reported, especially relating objective and subjective outcome measures. We carried out a prospective cohort study exploring neurosensory deficit in relation to LeFort 1 maxillary surgery. The primary objectives of the study were to assess the incidence and pattern of recovery of neurosensory deficit following LeFort 1 osteotomy. Secondary objectives were to investigate the relationship between age, gender, the extent of surgical movement on NSD, and to explore relationships between the subjective and objective outcome measures. 28 patients were followed up for 1 year and assessed at baseline, 1 week, 1 month, 6 months, and 12 months post-surgery, with a variety of objective testing methods applied to assess NSD at various extraoral and intraoral sites. Furthermore, participants completed a visual analog scale at the same time points for subjective analysis on how much the NSD bothered them. Full details of the methodology are described in the forthcoming publication. Objective evaluation found a high incidence of NSD immediately after surgery, particularly for intraoral mucosal sites. There is a gradual reduction in NSD, with the majority of improvement occurring between 1 to 6 months following surgery. The pattern of recovery is varied, with extraoral sites recovering to near baseline values between 1 to 3 months after surgery. Intraoral soft tissue sites take between 3 to 6 months to recover to near baseline values, suggesting their recovery is more prolonged. Furthermore, the maxillary dentition continues to recover from NSD up till the 12-month time point. Gender and extent of surgical movement did not influence the extent of NSD reported in our study. Increasing age appears to be a risk factor for NSD early after surgery at intraoral sites, especially in relation to the palate. There is a gradual reduction in how much neurosensory deficit bothers the patients, with the greatest improvements reported as occurring within the first 3 months following surgery. The results suggest patients are more sensitive to intraoral numbness in comparison to extraoral numbness. Furthermore, where NSD persists objectively, subjective reporting scores decrease, suggesting a reduction in how much neurosensory impairment bothers the patients over time. The findings from this study have important clinical implications for healthcare professionals involved in providing orthognathic care, in particular in relation to enhancing the consent process for informing patients regarding risks pertaining to NSD following LeFort 1 surgery. Furthermore, it can help in understanding the pattern of neurosensory changes observed following LeFort 1 surgery over a prolonged period of time and relate this to subjective patient perceptions, with the aim being to help counseling patients during the post-operative period. I hope you enjoy reading our full submission. Thank you.